Hi, my name is Brian Bizik. I'm speaking at the CARPS conference in beautiful San Diego. I work in Boise, Idaho, and I've been in the allergy immunology sector for about 7 years now. My topic this week is on recurrent infections and immunodeficiency. So my 3 points for this is, number one, with the diagnosis of patients with immunodeficiency, I'm often asked, how many infections is too many? Is there a line in the sand that you would draw, and after that you want to get them tested? And rather than a number, like a pure number of how many infections somebody has, I ask people to ask about the type of infection that they have. Are these infections unusual? If a patient is 5 or 6 years old and is in daycare and has a runny nose 3 or 4 times a year, that would be expected. Nothing about that is unusual. But a patient with 3 bacterial pneumonias in a year, that would be unusual. Most patients will not get infections like that recurrently. If they have a bacterial sinusitis or otitis over and over, and there's no real anatomic reason for that, that's another patient you might want to consider testing. So if the infections are more than normal or they seem unusual, if there's a family history of immunodeficiency, those are good patients to go ahead and investigate. And that brings me to the second point, the investigation and testing. If you're comfortable with testing, that's great, but you don't have to. Immunologists are happy to evaluate patients with recurrent infections, and just a referral is all that's needed. If you would like to do some testing, that's great as well. You can always test a CBC and a CMP, check to see where their white count is, and see if there's any obvious deficiencies. Checking antibody levels is also good. You can get an IgG, an IgM, and an IgA quite easily, and that'll tell you a lot. If you're comfortable, you can even go the next step and test for a patient's response to vaccines. That's another helpful test to decide if there might be an immunodeficiency. Again, if you don't want to test, don't. If you'd like to investigate more, that's great as well. Finally, it comes to the treatment of patients with immunodeficiencies. Somebody that's diagnosed and is being treated can be treated for routine infections in your office just like any other patient. If it's January and your patient comes in with a cough and they have body aches and fever, it's probably influenza, whether or not they have an immunodeficiency. So you're welcome to treat them. Common things are common, and that's true for the patient who lacks part of their immune system. Go ahead and treat them. The suggestions would be to treat a little bit quicker, so go ahead and not wait as long as you might for a patient that's otherwise healthy. Treat with broad spectrum antibiotics and treat a little longer. Most people recommend 14 days of antibiotics for patients with immunodeficiency. That way you can be sure to cover all the infections that they might have. Those are the recommendations that can help you go a long way to recognizing and treating your patients with immunodeficiency.